Okay, thank you for opportunity to me. I Nani, and as moderator will accompany you during Symposium Session 5. And today Symposium is entitled Nursing, Care Management in Nuclear Medicine Theranostic. In today's Symposium, there are two moderators, two speakers, Prof. Somanesan and Mr. Nahar Miladi.
It's okay, I'm using it.
Curriculum vitae Prof. Somanesan. Prof. Somanesan currently works as the senior principal medical physics at the Department of Nuclear Medicine and Molecular Imaging of the Singapore General Hospital for 35 years. I would like to invite the first speaker, Prof. Somanesan, to present material on administration targeted radionuclide therapy safety and quality management with a time of 15 minutes. Okay. Please.
Thank you very much, Chairperson, and a very good morning to all of you. Without any further ado, I hope I don't have any technical issues. A very quick introduction to my hospital. I come from Singapore General Hospital. It's about slightly more than 200 years old. It was set up during the British occupation in Singapore. At the same time, I wish to highlight that my hospital has been voted as a top 20 hospital for the last 7 years by the Newsweek magazine. And well, this is the breakdown. And as usual, as the other two speakers, I will try to speak as fast as I can. And all of you know that there's a success of radiopharmaceuticals, and that is driving the nuclear medicine theranostic market. What we used to do 40 over years ago was only a radioiodine treatment for CA thyroid as well as thyroid diseases. But now we have treatments for peptides, using peptides as well as PSMA for NETs and CA prostate respectively. And there are many different types of nuclides being utilized. And now terbium is also joining the other nuclides such as lutetium-177 as well. Now with that, you can see a very small snapshot. With a small country like Singapore, we have a growing number of NETs and PSMA as well. That small dip was due to COVID as well, because when there was a smaller demand. And I'm not going to talk much about this slide because the esteemed speakers before me have spoken much more in detail and much more about internal dosimetry and how important it is in personalized radiopharmaceutical therapy as well. Now with that, I want to highlight that the treatment that we have is not a single treatment, but it's multiple treatments. Just like chemotherapy has got multiple treatments as well. And the preliminary scan is also to determine the extent of the disease and the progress of the disease along the way as well. Now the post-treatment scans and dosimetry for the next few days, as highlighted by Danny and Kitiwat, is crucial. Of course, it's a bit painful as far as the department is concerned, the amount of time taken, at the same time the slots taken for the imaging, especially with the SPECT-CT as well. So our results that we have in Singapore General Hospital is similar to the international trends as well in terms of the treatment for all these at least these two types of cancers as well. Now there are a couple of methods in which we can do this infusion. It's a common theme is that either use a gravity method, okay, or the pump method with a vial, or pump method with a syringe shield. Now, I prefer, or the hospital prefers, the pump method with a syringe shield. And this is something that I will show you in this series of photographs that we have. As you can see, the physician basically looks at the patient, and you have this customized trolley that we have, stainless steel with a lead on the inside. The nurses setting up the infusion, and you can see on number 3, the infusion pump, all right? The regular infusion pump, nurses are very apt at using it as well. You can see this nurse setting up the infusion pump with the behind an L shield. So she's protected well protected. At the same time, the staff around the facility is also protected because of the customized syringe shield cover as well. Now, with that, we set up all those things, and then you can start. We'll talk about the safety aspects of it. Now, shielding generally, we are dealing with powerful beaters, high energy beaters, and which may have a low energy gamma, which is very useful for the imaging component. But unfortunately, when it comes to the radiation safety aspect, we have to look after the gamma aspects as well. So something like this kind of L shield, very typical of your technetium 99M L shield that you use in a 1A laboratory, for example, works perfectly. Because we are dealing with lutetium or even terbium or actinium for that matter. All of them have got low energy gammas, high energy betas and alphas. But what works for technetium works for them, right? It will not, something like this will not work for 511, okay? For PET imaging or iodine 131, it won't, because you need much more thicker lead because of the higher half value layer, higher 10th value layer for iodine as well as for fluorine 18. So, but it works perfectly for the low energy alpha and beta nuclides, okay? So this is you have a typical setup. And in your country, if you have to ward these patients, then perhaps isolation room with a special toilet, etc., may be needed as well. And you may have to have a shield so that the nurses can come and attend to the patients, take blood pressure, etc., and not be exposed to very high levels of radiation. You could buy this. And of course, this is set up for 360 keV, and you can actually utilize this for your therapy as well. And of course, you have monitoring as well. These pictures are from King Faisal Hospital, as well as in the States, when you actually see them actually drape the whole floor with this kind of disposable cloth. But why they use that is because they use this Zoom for other patients, maybe an orthopedic patient after the discharge of this, so that they don't want to contaminate the floor. But in our countries, it may not be possible, right? Because we have dedicated rooms for radionuclide therapy, as opposed to in the States, where they actually rotate the room from radionuclide therapy to other kinds of treatments, you know, orthopedic or otherwise. Right? So that's why they do that. And sometimes they use MIBG therapy. So MIBG therapy is a bit sticky. It sticks to on the floor as well. And to prevent any contamination that can be quite difficult to overcome, they use this paper. All right? Of course, it's not very green as well. Right. So with that, I want to highlight that you need to have the regular stuff that you have in all inpatient rooms. And you also need to dedicate a place where you can actually store this radioactive waste. And they maybe have vomiter smell. So you need to take care of the exhaust from such a facility as well. So stainless steel is the best because it's easy to clean. And of course, you need to have shielding of sheets of lead within the stainless steel cabinet as well. Right? So we have this kind of infusion where you actually can actually have outpatient kind of treatment. As you can see, the nurse is standing behind a very thick lead shield, suitable for 511. If it works for 511, it should work for your radionuclide therapy as well. Now, as you can see, a patient being infused with this for MIBG, iodine 131 MIBG, and you can see that the staff is actually standing behind the lead shield. Okay? Okay. Right. So the calibration of equipment is very crucial, as spoken by the esteemed speakers before. We need to calibrate the dose calibrator. We need to calibrate the scanner as well. It's extremely important, as what Kitiwat mentioned, especially for dosimetry purposes. But the dosimetry also is very crucial if you have a pure beta. How are you going to measure the dose calibration very effectively? Because pure betas don't have any gammas, right? So how are you going to determine the dose calibration activity, right? So if you have gammas, not a problem, like lutetium, for that matter, even terbium as well, has a gamma component. In its decay, you can actually measure it, but not for yttrium-90, which is a pure beta. And basically, you need to worry about the geometry factors, right, in a dose calibrator setup. Right. So with that, we talk about transport trolleys. You can't buy these things. You can't buy this from Europe, nor can you buy it from US. You've got to make it yourself. Number one, it's expensive to freight forward to your country. And number two, it's not customized to your requirement. But you have industry in your country, right? So you can make these things. And I can share the specifications of these trolleys if you wish. And of course, some of these trolleys, once you put on lead, they become 30 kilograms or 40 kilograms. It's impossible to push around. So you may need to have a DC motor attached to the floor because you may be traversing a long distance from your laboratory to your room where you're doing these treatments. So as you can see here, a customized lead shield trolley with the transfer of radiopharmaceutical as well. And this is a schematic of that. And the infusion pump. So I wish to highlight the general precautions needed for radionuclide therapy. One needs to wear your OSL, your TLD, and your EPD as well, so that you have spot reading, real-time readings of kind of exposure that your nurses and yourself are exposed to. And we, of course, we also don't encourage pregnant nurses to attend to these patients because ICRP as well as your local regulations requires that the pregnant staff not be dealing with high levels of radiation, and generally this will be high levels of radiation. Okay, and then certainly PPE, right? What works during COVID for all our countries works for contamination control as well. PPE in the sense that baju around over your clothing, your double gloves, your foot, masks, etc. Those are necessary. And less contamination means less exposure. And all of you know, in nuclear medicine, especially in nuclear medicine radionuclide therapy, you need to be very cognizant of the fact that you don't want to contaminate yourself. Because contaminating yourself with fluorine-18 is bad enough. You have a short half-life, but these nuclides have got much longer half-life, and therefore we must take double precautions not to contaminate our staff, our environment, as well as our colleagues as well, okay? So contamination protection, PPEs are crucial, as I had mentioned, and I strongly urge you to use double gloves as well, and change the outer gloves as frequent as you can. Right? So you keep your hands as clean as possible. And the fact that you need to also measure the radioactivity, ensure that your contamination is kept at bay, and every step of the way, measure how much contamination that you are going to make for your environment. Especially, we have learned very, very hard lessons about the fact that when we use infusion pumps, when the nurses use infusion pumps, there is always one drop post-therapy that falls onto the table. And nurses like to use a gauze around a sterile connector, right, when they're turning it. But the gauze is absorbent. But the gauze is also transfers the radioactivity from the connector to the tabletop, or for example. So these things, we have to rethink the way the nurses actually do this infusion, right? So zero tolerance for any contamination. But of course, you need to have backup. You need to have more than one syringe pump because we contaminate our syringe pumps quite frequently. And it's very difficult to decontaminate them, to make them zero activity or background activity. It takes a while. So it's always, when you want to start a new facility, please back up or have a few syringe pumps around so that you can actually use them. And perhaps shield them with plastic as well that can be easily cleaned for infection control, at the same time prevention of contamination as well. So some of the general measures: limit spread of contamination, notify your RSOs, use protective clothing, etc. Wipe up the spill, and everybody needs to know how to do spill decontamination. Everyone, so when there's a spill, you don't look for the RSO or the physicist, but you yourself can do these things. And using stuff that are set up in containers such as these that can be brought to wherever the treatment is occurring. So you do not leave the room and go to another room and collect it. So you don't have just one of this in the department, but several of this in the department. Pretty much every room that you have the treatment or infusion, etc. Right? So you can never be better prepared So, of course, recording of staff exposure is important because we want to know how much exposure our staff receive as well. Because this is a systemic sort of a service, and we do about like 7 therapies per week just using lutetium, be it peptides or PSMAs for NETs and prostate cancer, respectively. So, once again, survey is important. And current recommendation for the release of patients, well, this is a slightly old article by Kevin back in 2019. I'm sorry, it's not very clear. You can see these are the injected activities. They are in the range of about gigabecquerels, right? And if you can see on this side, this is for NETs, right, using DOTA peptides. The release level is about 12 to 15 microgray per hour at 1 meter away. So 1 urine is enough to bring the exposure down further, right? So these patients can be discharged based on the fact that their radiation exposure that they emit and what they can affect the public would be low enough. So most countries, we are using this sort of treatment on an outpatient basis, okay, without the need for an inpatient. So the risk of accidental intake is low for patients and caregivers, but one thing is that when you send them off as outpatient, we need to make sure that they are fully cognizant, fully understanding of the precautions they have to take. When they go home, they cannot go to the shopping center, for example, but when they go home straight, they have to flush the toilet 2 times, perhaps sleep in a separate bed from the others, and if they are pregnant ladies and children in the room or in the house, perhaps to keep a distance for a certain amount of time as well. So we need to give these instructions, verbal instructions and written instructions. Perhaps in Indonesia it will be in Bahasa as well, so it's easily understood as well. Okay? So travel advisory, we also give them a card so that they, when they are stopped at border control, they can account for the radioactivity, because some of these border controls have detectors, radiation detectors, and they may set out an alarm, and so as not to have an ugly incident, we give them a card so that the authorities know that this patient has just undergone a therapy and is traveling. Right. In summary, I wish to highlight that targeted radionuclide therapy is an effective treatment modality for some cancers and effective method of treating unresectable metastatic tumors. Several hospital radiopharmacies cater to needs of the large number of patients of progressive metastatic and advanced cancers, and the justification of the practice, the therapeutic benefits of the treatment outweigh the radiation safety issues. So yes, we can treat such a patient, and if the patient is willing to pay and has the capacity to pay as well, but we need to take care of the radiation safety aspects for our staff who are going to do this day in, day out for several years as well. So we, based on ALARA, we want to keep the dose to our staff as low as possible. So the other thing I want to highlight is optimization of protection and safety. So you need to know what you're dealing with, what kind of nuclide you're dealing with. Yes, alpha, but and therefore you take precautions with alpha in mind. So for example, alpha intake, because of its high LET, etc., we have zero tolerance for its contamination. So when you're dealing with alpha, you need to make sure that the lab is protected in such a way. You have a disposable cloth, paper, that can be disposed straight away, right? Between. So you have a setup that you use technetium and you mix it with alpha. You need to take care that the alpha doesn't contaminate your site, that will further contaminate your staff using it for technetium as well. So one needs to take care of the type of nuclides, and you need to study the kind of nuclide that you're dealing with, the properties, and how you can prevent contamination as well. So staff training is extremely important, and competency assessment for the training that you perform, decontamination, etc. All these have to be assessed for the competency as well. And lastly, I want to highlight that the emergency response. So you need to have a protocol. What happens if this radionuclide therapy ends up in the ICU? You need to know, you need to have an SOP for your hospital so that you can handle such a case if it happens. It has happened to me several times. So we have SOP, we have prepped the ICU how to handle this patient while keeping the radiation safety for the ICU staff normal, because the ICU staff are not radiation workers as well. Okay, I wish to thank you for the opportunity.
Thank you, Prof. Somanesan. Any question? Just one?
Okay.
Okay, please.
Thank you for the chance. My name is Samsiarni. I'm nurse in Dharma East Cancer Center in radiology nuclear. Actually, based on I'm working in radiology, also apply for FTG, but not yet. We don't have lutetium, not yet. Here, I want to make the same talk about how to protection and for the staff, especially us to give administer for the lutetium, because we don't start yet. But the FTG, we use like I see the picture on your picture. They're not wearing any apron. So in my question, when the time we need to make what protection that we need, like apron, or what we should prepare before to give the administer for the lutetium, or what the difference if we give like FDG or like technetium like this, how to protect for the us, because we give direct to the patient. Thank you, Prof.
Thank you very much for your question. I really appreciate your question. Yes, the important thing, there are two hazards in nuclear medicine. One is the radiation exposure that we receive from the patient, number one. Number two is the contamination, right? So the contamination is the possibility of contaminating our hands, our baju, and we can also take that radioactivity back home as well, right? So there are two hazards. We need to look after both of them. The first hazard is looking after yourself when you are injecting the patient, right? So there, as you correctly pointed out, you need to use the protection, right? Now you use the L-shield, for example, or automatic injection for FDG, for example, auto injection. So those are the ones that are able to cut down the radiation exposure. Now, talking about, as I mentioned in the talk, the type of nuclides is appropriate. You need to use appropriate shielding for the type of nuclides you're dealing with. 511 keV, as you correctly pointed out, has a very thick, you need a very thick layer of lead, and you cannot use lead apron, right? Lead apron is useless when it comes to F18 FDG, but yes, it has given the nurses a sense of safety, but it's a wrong sense of safety, right? Because when you are dealing with 511, the half-value layer of fluorine-18 for lead is about 13 centimeters, 13 millimeters, and it won't work, right? Because our lead apron is about 0.25, 0.5 millimeters. It's tachuko, you won't work at all. So in fact, you'll be inconveniencing yourself and your staff if you make them wear a lead apron, because you're going to stand up, sit down, and you get backache as well, right? For 8 hours of day. So therefore, use shield when you're doing 511. In the case of lutetium-177 and other kinds of radionuclides, the big issue here is the not so much as the energy of the gamma, but the contamination hazard. So for contamination hazard, please remember what worked for COVID-19. How you protect yourself as nurses, they were the best during COVID-19, right? The PPEs that are disposable are the best in terms of keeping the contamination down as almost zero. Okay? So yeah, thanks.
This is true, because we want to have the same mindset how to give protection from us for the like lutetium and for the FDG like this. Because some of us thinking like we have to protect, so we wearing all the apron like Google, like everything like this. So with this community, so in this chance, because we just meet like this one a year, so we want to make the same what we said tough about how we must prepare in, because most of us new about this, and most of us not familiar, because even me in cancer center, we not use lutetium yet.
True.
Only in
Absol-
private. Not yet.
Madam, you're not the only one,
Yes.
right? Around the world, they have the same
Yes,
issue,
yes.
right? But unfortunately, no one size fits all. So no one size of shoe fits every kinds of nuclides, right? Therefore, we need to look at the science of it, right? The science tells that every nuclide, you need to treat it differently. Technetium, a certain way, right? Fluorine-18 in a different way. Macam radionuclide therapy is slightly different as well, and we need to look after the characteristics of the nuclide we are protecting. Just like in nursing, you look after pathogens differently from cytotoxic drug, from biohazardous material, right? All different, not tada sama-sama kan. So therefore, for radionuclides also, you need to treat it differently. So please go back to your science, to your physicists, ask them to tell you.
Thank you, Prof.
No problem.
Thank you to Prof. Samarinda. We can give applause to Prof. Samarinda. If any question, we can scan barcode. We will share on group. Now, I'm sorry, my English is not very good. Next, I would like to invite the second resource person, Mr. Nahar Miladi, to present matter on inpatient therapy for RS nuclear medicine. Plakat dulu. Oh, satu. Oh, I'm sorry. We can give plakat before Mr. Nahar. Mau ngasih plakat. Ini aja. Please, Mrs. Rini. To give plakat for Prof. Samarinda. Applause, please. Thank you. Thank you, Mrs. Rini. Sudah. Sebutin kurikulum vitae aja Kak dulu, sebutin deh. Mau pakai bahasa Indonesia atau bahasa Inggris ya ini? Oh, bahasa Indonesia. Oke. Saya juga bahasa Inggrisnya setengah-setengah. Jadi baik, untuk pembicara kedua kepada Mr. Nahar Miladi. Sebutkan tanggal lahirnya enggak ini?
3 Agustus. Boleh.
Sebut aja. Baik, Mr. Nahar Miladi lahir di Bantul 3 Agustus 1987. Beliau bekerja di Rumah Sakit Sarjito, Yogyakarta, di bagian radioterapi dan kedokteran nuklir ya. Baik, kepada Mr. Nahar Miladi kami persilahkan untuk menyampaikan materinya, karena waktunya terbatas hanya 15 menit. 15 menit, oke. Kami persilahkan, terima kasih.
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera teman-teman perawat. Kemarin kita juga sudah membahas tentang pelayanan keperawatan ya. Ini khusus untuk hari ini saya akan menyampaikan untuk pelayanan rawat inap di kedokteran nuklir, tapi karena waktu terbatas, ini nanti akan saya percepat dan singkat saja. Oke. Terapi rawat inap di kedokteran nuklir kita selama 3 tahun ini full melayani, yaitu terapi ablasi yodium, terus samarium 153 dan terapi MIBG neuroblastoma, terutama pada anak. Selama ini sementara pada anak. Terus untuk pengertian, mungkin kita semua sudah tahu terapi yodium itu digunakan untuk terapi ablasi untuk pasien post operasi total tiroidektomi. Terus untuk persiapan pasien, untuk pasien baru itu pasti paling cepat dilakukan ablasi itu 4 minggu setelah total tiroidektomi. Itu pun kalau luka sangat bagus dan sangat bersih. Tapi kalau tidak, amannya kita lakukan ablasi itu paling cepat 6 minggu sebenarnya. Biasa untuk prosedurnya pasti dilakukan SKG, terus kalau untuk pasien lama tetap menganjurkan stop terapi hormonal yaitu 3-4 minggu. Terus dokter menganjurkan makanan mengandung yodium tinggi dihentikan 2 minggu sebelum dan sesudah terapi ablasi. Untuk cek lab rutin kita juga sudah tahu apa saja yang di lab. Untuk kontraindikasi absolut tetap cek kehamilan pada wanita 1 minggu sebelum terapi. Oke, lanjut. Setelah itu baru dilakukan penjadwalan. Nah, di sini peran perawat terkait penjadwalan ini sangat penting sekali karena kita sering pasien itu gagal karena ada miss di dalam penjadwalan. Peran perawat yaitu melakukan pendampingan pasien yang ada di rumah. Jadi kan kalau dokter sudah menjadwalkan terus sudah menganjurkan untuk stop 3 minggu terapi hormonal dan paling enggak 3 hari sebelum hari H ablasi itu untuk kontrol. Nah ini peran perawat itu pendampingan kita nanti selalu menghubungi pasien di tanggal-tanggal tersebut entah melalui WA atau melalui telepon. Yang penting harus terkonfirmasi. Dulu waktu awal-awal pelayanan kita belum seperti itu, jadi sering rugi obat sia-sia. Jadi sekarang sudah ada perbaikan dan ini sangat efektif sekali. Pasien selama 2 tahun ini selalu full penuh. Dan kalau gagal karena terkait belum stop obat dan lain-lain itu kita bisa ganti pasien. Untuk alur pasien masuk ini singkat saja di semua rumah sakit pasti seperti itu. Dari pasien masuk ke pendaftaran entah dari online atau datang langsung itu melakukan registrasi terus langsung nanti ke asesmen perawat di perawat poli terus dari perawat poli masuk ke dokter di PJP. Setelah itu kembali ke loket pendaftaran untuk diantarkan nanti pasien ke ruang rawat inap kedokteran nuklir. Setelah itu setelah pasien masuk ruang rawat inap itu diterima oleh perawat yang jaga di RIRA dan dilakukan edukasi kolaborasi. Ini contoh gambar saat kita edukasi kolaborasi. Dalam edukasi kolaborasi ada dokter, petugas farmasi, petugas PPR, terus dari perawat sendiri dan yang terakhir dari ahli gizi. Jadi kita kumpulkan langsung terus kita edukasi kolaborasi, baru setelah itu peran perawat memasukkan pasien ke kamarnya masing-masing. Dan sebelumnya tentu saja untuk edukasi perawat itu yang utama adalah orientasi seluruh ruang dan mengajarkan pasien untuk minum obat yodium. Ya. Selanjutnya ini untuk prosedur cara minum terapi yodium yaitu biasa sama. Kalau di Sarjito masih menggunakan yang wujudnya cair ya, kan ada yang kapsul juga. Itu pertimbangan dari dokter sih karena kalau kapsul itu pernah kejadian ada yang alergi sampai Stephen Johnson. Jadi sebenarnya udah ada yang nawari tapi dokter kami nggak berani. Padahal menguntungkan perawat sebenarnya. enak ya toh. Terus biasa untuk pasien-pasien yang baru tetap kita dampingi. Kalau pasien yang lama dan sudah mandiri itu sudah kita awasi dari jauh saja. Ya. Terus untuk pasien-pasien yang keterbatasan ini salah satu kendala kita. Kita benar-benar tetap harus memastikan pasien itu obat masuk dan tidak terjadi kontaminasi. Karena pernah ini saya sendiri ya, nun sewu, pasien itu PD, ya memang pasiennya sudah tua, itu pasien PD mau minum sendiri. Saya malah disuruh nggak lihat. Kok ternyata itu flakonnya itu diangkat, jatuh, tapi alhamdulillah tidak pecah. Jadi sejak saat itu saya tetap tak awasi, tak dampingi sampai pasien minum. Untuk monitor, biasa monitor efek samping obat yodium, ada mual, pusing, perasaan sesak, tapi di sini yang sering muncul adalah pusing dan mual. Kalau untuk sesak nafas sementara ini tidak ada. Terus untuk selanjutnya, ini contoh gambar pasien yang mandiri. Ini secara mandiri minum obat yodium. Biasa pasien nanti buka sendiri, kita kasih sedotan, terus menyedot obat yodium, nanti terus dibilas sendiri. Terus edukasi kita juga 2 jam setelah minum terapi yodium baru boleh makan. Oke. Lanjut, masalah keperawatan yang mungkin muncul biasa, resiko kontaminasi, resiko cedera fisik, ansietas berat, mual, nyeri akut. Yang terakhir ini bukan saya memasukkan ini, resiko kesepian berat ini maksudnya. Ini teman saya yang kuliah, jadi masih idealis banget, dimasukkan padahal kayaknya pasiennya cuma 3 hari nggak ada yang kesepian, kayaknya perawatnya sendiri ini yang kesepian. Lanjut. Oke, daftar pustaka cepat saja. Ini terapi samarium biasa. Samarium di kita itu sebulan pasti ada, kadang 2 kali, kadang triple 3 kali. Tergantung Pak Dokter. Terus terapinya adalah terapi nyeri yang menggunakan Samarinda 153, dan terapi tersebut merupakan terapi paliatif yang ditandai atau dilihat dari metastasis tulang dengan sebelumnya di bone scan dilihat dari ada aktivitas osteoblastik pada sidik tulang. Untuk persiapan terapi samarium biasa cuma berat badan, nanti untuk penentuan dosis. Untuk darah rutin, bone scan itu kalau di tempat kita, kalau bone scan-nya itu lebih dari 3 bulan pasti kita ulang. Terus untuk pemeriksaan fungsi ginjal biasa ureum kreatinin. Sama lagi untuk kesiapan pemeriksaan hematologi, ini ada HB harus di atas 9, terus leukosit 3,5, tapi ini biasanya Pak Dokter di tempat kita itu tetap dilihat klinis pasien juga. Kadang misal trombosit di bawah 100, kadang juga berani. Terus edukasi pasien, untuk yang ditekankan pada edukasi pasien ini untuk pasien samarium yaitu terapi samarium itu bukan untuk menyembuhkan penyakit, tetapi sebenarnya untuk meningkatkan kualitas hidup saja. Jadi untuk nyeri, untuk mengurangi nyeri saja supaya, tapi pasien-pasien ini tetap dapat anti nyeri. Anti nyeri biasanya mungkin pakai MST, nanti setelah di samarium mungkin hanya paracetamol. Jadi hanya untuk meningkatkan kualitas hidup. Terus dalam perawatan pasien samarium ini akan muncul nyeri flare selama 12 sampai 24 jam itu saat kita rawat, itu biasanya pasien akan ada nyeri flare, itu nyeri yang hebat karena itu sebagai tanda samariumnya itu bekerja. Terus efek muncul mulai enak biasanya di tempat kita setelah kita evaluasi seminggu sampai 2 minggu baru muncul nyerinya berkurang. Okay. Untuk persiapan administratif biasa, samarium harus tersedia, terus pastikan pasien itu terjadwal, dan kalau satu aja gagal ya kita rugi dan lain-lain, pokoknya hanya persyaratan itu saja. Ini contoh pasien Samarinda. Pasien Samarinda di tempat itu rata-rata semuanya ADL dibantu, tergantung. Dalam hal itu kita tetap libatkan keluarga dengan menggunakan APD, kita ajari dulu, edukasi dulu untuk keluarga menggunakan APD. Tapi nanti kalau keluarga kesulitan, tetap perawat juga turun tangan ikut membantu. Tapi tetap kita minimalkan. Untuk prosedurnya biasa, radiofarmasis menyiapkan obat Samarium dengan dosis sesuai instruksi dokter. Setelah masuk di ruang rawat inap, nanti perawat tinggal memasukkan obat secara IV. Sebelumnya kita pasang len, yaitu 3W. 3W saja, nanti dibilas dengan NaCl 10 cc. Untuk syarat keluarnya pasien yaitu 300 mikrosievert saat mau keluar, diukur 300 mikrosievert. Tapi rata-rata juga selama ini kita rawat inap satu hari satu malam juga sudah di bawah 300 mikrosievert. Untuk pencitraan pasien juga di hari berikutnya. Ini contoh gambar teman saya dalam memasang IV line. Pasti semua kita pasang IV line saat mau di Samarium. Untuk masalah yang sering dihadapi yaitu nyeri kronis, resiko kontaminasi, ansietas, intoleransi aktivitas, keletihan, dan resiko cedera. Biasa, lanjut. Ini contoh gambar saat teman kita memberikan terapi Samarium di kamar masing-masing. Nah, sudah. Nah, ini terapi MIBG. Saya MIBG kan kemarin dari Pak Noto sudah dijelaskan detail ya Mas ya. Ini saya tinggal apa aja yang perbedaan dari Semarang, dari Karyadi dan Jogja ya. Kalau dalam prinsip pemberian sama, terapi MIBG dari Karyadi kemarin juga 30 menit sampai 60 menit pemberian MIBG. Di tempat kita juga sama. Untuk pemberiannya juga menggunakan sharing pump sama. Saya juga kemarin malah kaget, jadi ternyata di Karyadi sering muncul efek samping, pernah muncul efek samping seperti itu. Itu buat pembelajaran kita, karena kalau MIBG sendiri kita itu jarang, baru setahun ini itu karena waktu konklin sama spesialis anak, itu dari spesialis anak itu menginginkan memakai yodium, MIBG yodium 1, 2, 3. Kalau kita kan bisanya 1, 3, 1. Karena kalau 1, 2, 3 itu cuma memancarkan gamma ya toh. Jadi kalau anak itu kan agak sedikit berhati-hati dari dokter spesialis itu. Jadi untuk pasien-pasien MIBG di kita evaluasinya itu susah. Karena setelah kita lakukan MIBG penceritaan, kita kirim, tetap kita beri kesan dan saran untuk besok 6 bulan lagi MIBG diagnostik. Tapi dari mereka kadang enggak ngirim lagi pasien ke kita. Cuma itu kalau MIBG sahnya. Untuk persiapannya sama nggih, untuk pasien MIBG stop obat yaitu banyak ada labelatol, reserpin, kemarin juga psikotropika, kalau ada dihentikan. Untuk persiapan pasien diberikan blokade tiroid 1 hari dengan lugol sebelum penyuntikan radiofarmaka, dan 2 atau sampai 3 hari setelah penyuntikan radiofarmaka. Kalau di Semarang kan bisa sampai 15 hari ya Mas. Ini contoh pasien anak di tempat kita untuk dilakukan terapi MIBG. Ini obat-obat yang bisa di stop banyak sekali, tidak perlu saya sebutkan. Hampir sama untuk prosedur pemberiannya, yaitu intravena 30-60 bulan menggunakan infus pump, sharing pump sebenarnya. Pakai infus pump jarang kita, nggak pernah malah. Perawat monitor vital sign 15 menit dan 30 menit setelah pemberian MIBG, sama seperti kemarin. Kalau kemarin kan 2 jam pertama itu 15 menit vital sign terus. Habis itu baru per 8 jam kita untuk pasien keluar itu sama seperti terapi yodium, yaitu di bawah 70 mikrosievert. Oke. Dalam perawatan di terapi MEBG itu karena pasien anak-anak kita memang benar kesulitan terkait pasti harus ada pendamping pasien. Orang tua itu untuk mendampingi pasien itu paling susah untuk diminta memakai apron. Jadi ya benar seperti kemarin apa adanya. Yang penting kita ada inform consent gitu Mas. Lanjut terus terapi MBG, pemantauan pasca terapi sama tindak lanjut pasca terapi, evaluasi klinis dan laboratorium pasti 1 minggu setelahnya, terus sidik seluruh tubuh MFG untuk menilai respon. Lah ini yang jarang pasien dari spesialis anak jarang mengirim. Terus pertimbangan terapi ulang jika progres atau respon. Lah ini untuk 2-3 ini kan kita harus kolaborasi dengan pasien spesialis dokter spesialis anak karena kita ngirim. Jadi kalau beliau menghendaki kan terus ngerujuk lagi ke kita. Gitu. Untuk diagnosa perawatan, resiko cedera radiasi, mual, takut, konflik peran orang tua, resiko perkembangan tertunda. Daftar pustaka, terima kasih. Ini yang penting untuk kendala dalam pemberian terapi. Rata-rata kemarin saya juga sudah sharing dengan teman-teman. Memang dalam pemberian terapi itu kita di Sarjito sendiri itu kendalanya adalah pasien dengan ADL penuh dan dibantu. Karena banyak kita sudah menemui sering sekali untuk pasien dengan ADL dibantu atau ketergantungan. Kita harus benar-benar ikut berperan dalam pemenuhan ADL dan keluarga. Terus pasien dengan gangguan psikiatri, pernah pasien jiwa masuk ablasi di tempat kita pernah pasien jiwa masuk ablasi itu kita harus memastikan obat-obat jiwa kan tetap harus terminum. Kadang kan ke pasien jiwa karena merasa nggak sakit kan minta terus di bank. Ini pernah di tempat kita. Mungkin pertimbangan dokter karena high risk mungkin ya, jadi harus di ablasi cepat. Terus pasien-pasien demensia ini juga banyak dan sering. Bahkan saya sendiri pas jaga pernah pasien itu tak tinggal sholat maghrib. Waktu saya habis sholat maghrib saya mau ngecek kok pasiennya nggak ada. Kemana? Ternyata sudah di depan rumah sakit cari Gojek. Wah ini tetap deg-degan tenan itu. Itu nih rahasia nih Pak Dokter, saya Dokter Hanif nggak tahu ini, kalau tahu mungkin udah dipindah dari dulu. Pasien bisa lari. Terus ini cara memakai APD terakhir. Oke, slide terakhir ini untuk pendamping. Kita sudah edukasi tapi pendamping itu benar-benar ngayal untuk memakai APD. Terima kasih. Nah, ini ya. Ini cara memakai APD untuk pendamping pasien. Seharusnya tata cara seperti ini, pakai apron atas bawah, terus pakai gaun, tapi tetap memang susah untuk itu. Terima kasih karena kemarin juga sudah banyak mengetahui materi MFG. Kalau ada pertanyaan silakan kita sharing aja. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih buat Mas Nahar atas materinya. Karena waktunya mepet untuk sholat Jumat, aplaus dulu ya buat Mas Nahar. Mas Nahar benar. Karena waktunya mepet untuk sholat Jumat, jadi untuk pertanyaan nanti silahkan di Wapri atau di grup saja. Terus nanti akan ada barcode juga yang akan di-share ke grup untuk bertanya. Tapi sepertinya lebih enak Wapri ya Mas Nahar ya. Baik, sesi terakhir itu saya minta tolong untuk Bang Martoni untuk menyerahkan plakat kepada Mas Nahar. Aplaus juga buat Bang Martoni. Ini suhunya ini kemarin nggak datang ya. Kalungnya belum tuh. Kalungnya iya, dikalungin dong kadang-kadang. Baik, terima kasih. Saya tutup acara ini dengan belum foto dulu, sesi foto dulu. Baik, terima kasih. Saya tutup acara ini dengan wassalamualaikum warahmatullahi wabarakatuh. Wapri aja langsung.